Briefly, we have data from the NCI and the consortium they put together that prior Blinatumomab may not be so good if you're going into CAR T-cell immunotherapy. So one of the questions we wanted to answer, one of the things we wanted to do is do a deep dive. What happened from a survival perspective, from a duration of remission perspective, from a toxicity perspective, from an expansion perspective, what happened in those patients who had prior Blinatumomab before CAR T-cell therapy? We presented actually at we presented at a prior ASCO meeting that prior Blina was not associated with any impact in response rates. When we published the Lancet manuscript in the subgroup analysis, we also did not see a statistical impact on response rate. That was very, very encouraging. And so we wanted to then step back and say, okay, well then what, is this real? We looked at DOR, duration of remission, and again, no clear impact on the duration of remission. So it seems like we were getting good responses. And when we saw a response, those durations were preserved. What was fascinating is when we looked at the survival analysis. So those patients who had prior Blinatumomab appeared, and again, with small numbers, prior Blinatumomab exposures, those patients seemed to do worse from a survival perspective. Now, one of the hard parts is those patients who received prior Blinatumomab were more likely heavily pretreated, more likely coming on with higher blast burdens. In other words, they took on some of those characteristics that we know are associated with inferior outcomes. And so I think that the Blinatumomab question is one that's going to require a little more nuance in terms of storytelling, especially when we see that these DOR curves essentially overlap. We also wanted to understand the role of allogeneic stem cell transplant, both for those who had a prior allo before CAR T-cell therapy and for those who had an allo after. So for those who had a prior allo before, one of the questions is, well, maybe we'll see enhanced T-cell expansion. We'll see better remissions, better remission duration. Why? Well, they're more, in general, immune suppressed. And so we might speculate they would do better. On the other hand, they're also more likely more heavily pretreated, right? They may be less fludarabine sensitive. We may get less in terms of our T-cell activity by that simple virtue of fludarabine resistance. And there's a lot of really interesting papers, by the way, that are being developed around fludarabine PK and fludarabine AUCs. And so we looked, and the answer is we didn't see much. We want to understand the role of transplant after CAR T. And again, another really interesting question. We looked in the data set we presented here at ASCO, and we found that 6 out of the 10 patients who received a prior allo were still alive at last follow-up. And that's really good. Certainly, transplant never performs that well in a relapse refractory population, with the caveat that it's 10 patients. I was talking to Dr. D'Angelo the other day, and he made a really good point that median overall survival may not be the best measure of whether a transplant benefits these patients. It may be more important to understand what's happening on the tail end of the curve. Are these patients alive and staying in remission? And if that's the case, maybe it makes sense to take transplant to those patients, because we're always going to have this problem of transplant-related mortality that's going to be an early event.